My name is Andrew Edgeluni. I'm an orthopedic surgeon specializing in hip and knee arthroplasty. So I learned about the medial pivot implant actually a long time ago in my fellowship, and have kind of rekindled my interest in the past 5 to 6 years. The initial design was done at the University of Michigan, which is not too far from the Detroit metro area. So I've heard of this implant, and I did some exploration myself. Two things that intrigued me about this implant are the stability of the implant and the ability to actually remove the ACL and PCL and not remove bone. As an implant surgeon, I always look for the next surgery that I'm gonna have to perform, and it allows me to keep more bone stock if I have to do a revision surgery. Evolution knee replacement system intrigues me because of the single radius design that's able to capture the medial side. It can have a more ball and socket medial portion with more rollback on the lateral aspect of the femur. So actually the kinematics of the knee is more like a natural knee, allowing you to not have to balance the PCL, and removing the ACL is a huge benefit. I have performed total knee arthroplasties with many different implant companies. Using the Evolution knee, one thing I've noticed to be the most beneficial is mid-flexion instability. You do not see that as much with a traditional knee replacement using a CR or a PS, because the medial portion of the knee is very congruent, and so you don't see this mid-flexion instability, which is a huge complaint with patients going up and down stairs, squatting, getting off a low chair. The learning curve with the Evolution medial pivot is very simple. It's basically recognizing the different instrumentation and understanding the design philosophy of the flexion and extension gaps being minimally different. So you want to have the flexion gap to be about 1 millimeter larger than the extension gap, and that allows you for the ball and socket motion of the medial side and the lateral rollback of the lateral side.
Alexander Saw, hip and knee replacement. My history using total knee replacement is, like most, I was using what I was trained with in fellowship or residency. By far, that's the most common pattern of how people choose their implant system, simply because they're comfortable with it. But as I got more into practice, I started to try to fine-tune things, just like I would with my pain management strategies, just like I would with my surgical technique. I started to look a little bit deeper into the actual implant that I was using. And what I found was that, just similar to the way that patients are seeking better ways to have better outcomes, they're seeking surgeons who can do things a particular way, I realized I needed to choose an implant that could really provide the patients I was serving the outcomes and recovery that they wanted. I was very happy with the implants I was using, but the question was, could I do something better? Was there something that I was missing that perhaps my patients were not being exposed to simply because I didn't know enough about it? When I was talking with colleagues who were using this implant, they were raving about the results they were seeing in their patients. They were telling me that patients were recovering sooner, that they were having less pain, they were using less opioids. Of course, that got my attention, because anything I can do to provide my patients a better result, I want to know about. Patients were also giving testimonials, saying how well it worked. I was seeing patients who had that surgery done somewhere else come in and tell me that that worked well. They were coming to me for their second surgery, but it was interesting to hear how well they were doing with this implant and this technique. And so that really drove my interest to look into it further and to try the implant for myself. What I found was that many of the things I was being told were true. So patients were having less pain, patients were recovering sooner. Most importantly, they were feeling a more stable knee. So I think a lot of what people will tell you is that with the Microport medial pivot design, there is more inherent stability so that people feel it more natural to them.
My name is Don Kanapke, and my specialty is orthopedics, and in particular adult reconstruction. Medial pivot knee is a very unique knee. A lot of the other knee systems have traditional J curves on the femoral side. The medial pivot knee is just totally different, more stable on the medial side. And that lends itself, if a person wants to release the PCL, it allows you to do a PCL, a cruciate sacrificing knee replacement without cutting the box. And other systems, they have posterior stabilized components, and then they have cruciate retaining, and generally you keep the PCL for those types of implants. And so I think that the medial pivot knee is different in that way. The key is the heightened sense of stability that you get, and I think that's why the patients do great with it. The medial pivot knee, if you do a nice job, there's just no mid-flexion instability. So my experience with it is the patient just likes the knee. It feels really good to them really fast. They tend to get their range of motion much quicker. I think they get back to their activities of daily living just quicker. Ultimately, what a knee replacement specialist doesn't want to see is their own knees that they thought they did a good job having any problems. And so what you see with the medial pivot knee versus maybe when I was doing other knees more commonly is less issues, just less problems, less trouble where somebody's having pain, swelling. Either they're not that happy or they're not happy and actually want to have something done. So less problems with the medial pivot knee really is the biggest thing. The happiest thing for us is just everybody's happy. We don't have any, not having any complications. That's what's great. So medial pivot knee is just a very reliable knee. We don't see problems.
Matt Prince, orthopedic surgeon with a fellowship in sports medicine. Coming out of fellowship, I was a PS knee guy. I think a lot of sports guys feel that the idea of balancing the PCL is not the best way of doing things, and the PS was kind of the standard that we used. As I came out, the first couple years, I was introduced to the medial pivot, and it allowed for me to not change my technique at all in the way I do the knee, but got rid of a lot of the complaints that I had about a PS knee. One of the biggest things in total knee is consistency. When there's a lot of variability in the way that you do things, if you're sometimes using a CR, but then in the patients that are bad deformity, then you're using a PS, that's just one more level of variability. The beauty of the medial pivot is that it really is a one-size-fits-all. For my most active patients that are in their 40s and 50s box jumping to my 80-year-olds who are just trying to walk a mile a day. And in that, I don't have to change my technique, whether it's a straightforward total knee or a bad deformity. It can do everything the exact same way. And the more you can cut down variability, the better your outcomes are going to be. The research I did on it initially after I was told about it, the real kinematics and theory behind the knee make perfect sense. We're never going to completely recreate what a standard knee is, or a native knee, but the kinematics of this knee really do come about as close as you can. You can see other companies trying to pick up the same type of idea, but it's definitely different. Just putting in a bearing that's ultra congruent, or however you want to call it, but still keeping your same prosthesis that, as far as the femur goes, that has changing radius or a J curve. You're never going to get that same conformity that we have with a single radius knee, like the medial pivot. And again, using it made perfect sense to me because, there's been plenty of studies showing satisfaction when it comes to how a knee feels, comparing a bicruciate retaining to a CR knee, to a PS knee, to a medial pivot, and actually in people that have had one of each. And universally, the medial pivot does as well as a bicruciate retaining knee as far as satisfaction, without the obvious failures that we've seen with the bicruciate.
Hey, my name is Michael Wagner. I'm an orthopedic surgeon specializing in adult reconstruction orthopedics, which means I basically do advanced hip and knee replacements. I was first brought to Microport and the Evolution knee by having the ability to go work and shadow a physician that I worked with as a resident, who I now consider a colleague and a friend, and watch him do a couple surgeries. And when we do knee replacements, unfortunately, we do have to sacrifice a couple pieces of anatomy that are just unavoidable. The medial meniscus, the lateral meniscus, the ACL, and sometimes the PCL are just unable to be replicated with metal and plastic as we have it today. And that falls into one of those categories where, as we try and recreate normal anatomy, we're still trying to work with metal and plastic to do those tricks. And that's where Evolution was able to help me with the medial pivot system to create a more constrained inside component whilst continuing to have the outside of the knee still translate like a normal knee should. And watching him really gave me the impetus to kind of take that jump into the deep end and try it myself. For anyone considering to utilize the KA technique and to pair that with Evolution, I would just say seeing is believing. And go shadow someone, come see one done, get your hands on a cadaver, and I'm fairly confident you won't look back. As you try to integrate that into your own practice, stick with run-of-the-mill arthritis patients. Normal body habitus, not going to get into the extremes of sizes or musculature. Normal varus knees are the bread and butter of kinematic alignment. But that being said, there's nothing that makes me happier than doing a valgus knee with kinematic. So long as there is normal anatomy there and it's not related to a significant hypoplastic lateral condyle, there is nothing better than doing kinematic alignment and really limiting your bony resections and putting a 10 millimeter polyethylene insert in a knee that we historically have chased with polys up to the 14, 16s, and 18s.